Hi, this is Philip Pador, founder of NCLEX Iron 45-Day Challenge. In this video, I'm going to be talking about urinary incontinence. Urinary incontinence is twice more common in women than in men. About 1 out of 3 women over the age of 60 is estimated to be incontinent. Pregnancy, childbirth, hormonal changes during menopause, and anatomy of the urinary tract account for this difference. Urine is produced in the kidneys and stored in the urinary bladder. Urination is the process of emptying the bladder through the urethra that connects the urinary bladder to the external urethral orifice. There are 2 types of sphincters or valves that keep the urethra closed to prevent leaks. The internal urethral sphincter, located at the neck of the bladder, and the external urethral sphincter, located at the right above the external urethral orifice and supported by the pelvic floor muscles. The urethra is much shorter in women than in men. When the bladder is full stretch, receptors in the wall of the bladder send a signal to the spinal cord and the brain. At times, when it's not appropriate to urinate, the brain sends back an inhibitory signals to keep the sphincters closed and to prevent voiding. When you wish to urinate, the inhibition is removed. The spinal cord instructs the muscles of the bladder to contract in the sphincters to open and let the urine out. The urinary incontinence is involuntary leakage of the urine. There are several types of urinary incontinence in women. Stress incontinence, the urine leakage while sneezing, coughing, laughing, or an inactivity that creates abnormal pressure on the bladder. This usually occurs because the muscles of the tissues underneath the bladder are weakened and can no longer support it. In women, this typically happens as a result of pregnancy and childbirth, during which these muscles are overstretched. Stress incontinence symptoms usually worsens during certain times of the menstrual cycles when estrogen level is low. Incidence also increase following the menopause. This is by far the most common type of incontinence in women. Urge incontinence need to avoid that cannot be deferred to inability to hold. This is commonly caused by an overactive bladder, a condition in which muscles in the wall of the bladder contract in an uncontrollable manner. Overflow incontinence, constant dribbling of the urine. This happens when the bladder does not empty properly while voiding, making it almost always full, and urine overflows. This may be due to the weakened muscles in the bladder wall or blocked or narrowed urethra. This type of incontinence is rare in women. Treatment depends on the type of incontinence and severity of symptoms. Lifestyle changes limits fluids intake at the certain times of the day, such as before going to bed or before long trip. However, note should be taken to increase the fibrous contents in your meals to prevent constipation. Cut down on the caffeine, alcohol, and keep healthy and in weight. Try pelvic floor muscles exercise such as Kegel exercises. This is to strengthen the muscles that support your bladder and particularly recommended after the childbirth. Timed voiding or bladder training therapy. Plan regular trips to the bathroom and set times of the day. Gradually increase the interval between trips as you gain control. Small leakage can be managed by wearing menstrual pads. Medications depending on the cause of incontinence, following types of drugs may be prescribed. Anticholinergics. This acts on the nerves to block the bladder spasms for treatment of the overactive bladders. For stress incontinence, topical estrogens may be applied as a cream or a patch. Estrogen helps to tone muscles and tissues around the urethra to keep it close. Non-surgical therapies for stress incontinence include pessary. A ring-shaped medical device can be inserted into the vagina to hold up the bladder neck. The ring needs to be taken out and cleaned regularly. Bulking agent injections. Bulking materials such as collagens and carbon-coated beads can be injected into the area surrounding the urethra to support and keep it close. These minimal invasive procedures but usually has to be prepared to be effective in the long term. Surgical procedures include sacral nerve stimulations, treatment for overactive bladder that does not respond to the medication. a small pulse generator device implanted under the skin of the body. The device sends mild electrical impulses to sacral nerve. The nerve then controls the bladder activity to moderate and control the bladder spasms. Bladder suspensions or sling procedures may be performed to create an artificial support for the bladder neck or the urethral sphincters. These procedures usually involve tightening of the bladder neck or the urethra to strong ligaments within the pelvis or to the pubic bones.